All right, good afternoon, everyone. Hope you're able to hear me okay. I'm Bobby Jefferson. And as you heard earlier, technology guy, 15 years supporting projects, technology projects. So if I use too much technical terms, just stop me, throw something at me, tell me to stop, or explain any acronyms, because the purpose of this is not around technology. The purpose of this whole presentation is to help you. Because when I attended the Social Innovators Forum and conferences here, the most important part I wanted to get from every presentation was, what can I take home? So I'm hoping very much that at the end I can leave you with something that you can use. So my first question for the audience is, do you have a mobile phone? If you have, can you just raise it up? Perfect. If you have a mobile phone, you have a solution. And I want you to remember that. That's very key. So, fancy technology, databases, et cetera, et cetera, et cetera. A simple, low-end mobile phone that you didn't purchase for them in the countries is one of the solutions that can be used. And I'll show you that as an example. So, I currently manage a team of about 140 software developers, engineers, public health folks in about 10 countries. And we're managing a large program in Kenya and Tanzania around antenatal care, PMTCT, HIV, malaria, that sort of thing. But what excites me very much is that the work that we're doing is not for the top 1%. It's for the poorest of the poor, the rural, those who really can't afford the services. So they tend not to have internet. They tend not to know computers. The literacy rate is low. How do you provide technology, health, and other solutions to those types of people? So this is rural Nigeria. This is one of the clinics and hospitals that I work at. We help support, and solutions work there. So it's one of the faith-based hospitals, one of the faith-based clinics. So all you technology people who are thinking about these cloud-based solutions and all this fancy stuff, if your stuff can work here, please, let's talk. Because that's what's needed. What's needed is not so much the fanciness and the expensive technologies, but what's really needed is what works on the ground, in the field, locally. And so in rural Nigeria, rural Tanzania, rural Rwanda, places that do not have internet connection, cannot afford internet connection, cannot afford airtime, cannot have a phone that has power on it. These are the real life challenges. So to get to these places, of course, you've seen this type of picture earlier today, very difficult, remote, that sort of thing. But what we've been using in Tanzania and a few other countries has been the mobile phone, and the mobile phone solution around SMS and USSD and that sort of thing, because that works very nicely in the countries. But what works even nicer is that they feel empowered. So if you have a program around mobile, it's very easy today to download a piece of mobile software and start using it. If you're a local NGO, if the director of CDC or PEPFAR came to you Monday morning and said, you're now going out to rural Nigeria and you have to go select a piece of software, you're able to go to the internet today, download that, and use it. The question then becomes why and what type of software would you select? What kind of solution would you choose without having to have talked to people in country, without having talked to people that actually are going to use the software, without actually going to use a solution? So what we've tried to do is take the opposite approach. So in this case, this is Mary, and her job is to record antenatal care register, these big, huge books. She has to report every month to the Department of Health. And so we said, we're going to introduce this fancy, nice technology for mobile, and you can see her texting now and sending it in, and we said, wow, this is going to be a great success. And it was, until she said, Bobby, you and your fancy mobile phone technology, I was actually getting paid to carry the register to the department, drop it off, and get per diem. So even though we introduced this nice technology, what she wanted more was that per diem in order to go and actually deliver the paper records. So of course, now our data started getting bad and less use because we hadn't really addressed the issue that she was concerned about. So what we did then was, let's see if it's there. Oh. What we did was we included, instead of paying people per diem, we included airtime to her. So as she delivered the reports on time, we would give her as a reward and incentive a couple shillings airtime as a reward for sending the reports on time. And then she was very happy, right? So again, and the key part for this is there's always a human nature and a human factor to the technology. So, and that's much more important to the success of it and the sustainability of it than just about everything else. We're also doing a project, DFID funded project in Bihar and Orissa, where I have to go out and manage 18,000 private clinics in the next past 6 months, and 90,000 clinics in the next 18 months. And so this is another large-scale effort. I'm going to be doing mobile. So now, the nice part about India is, if you want to do things at scale, does your fancy technology work at scale? India is a fantastic place to do it, because you can just have a single block or a single state, and you'll have 300 million people to work with. And so if it can work in India at scale, it works in other places as well. So we've got a number of mobile projects and programs going on that are managing those clinics, those 18,000 clinics today. So I can address a couple of issues. One is not doing things for pilot purposes, and the second is how to do things so that you build them to scale immediately, right? Because what happens in mobile projects, there's at least 100,000, I think the most recent study was 90,000 mobile health projects that are occurring today in Africa and Southeast Asia. And in Tanzania and Kenya alone, there's documented over 400 mobile health projects, all pilots, right? So everyone, again, you can just download, start, done. It's not sustainable. It's not the right way to take the approach for the long term. And so how to build and use the right technology so that way it's sustainable after your funding's gone, after you return back to the US, after you're leaving this fancy technology with people, how to keep it going when they don't have any money. And again, I've experienced that with my funding, year 1, year 2, and year 5, it goes like this. And yet the projects are still going on and still being used, so I'm very successful about that. So in India, we've got the projects where we have a mobile van that's going around and visiting the different patients as well, and we've got a mobile piece in there. If you've got a used tablet, e-reader, you've gone onto a color version, what we do is we'll take your old version and we'll just, change the operating system, just put on the little software that allows for data capture for our surveys, and then we'll connect it to a solar panel. So that way it can charge off the solar panel, so that way the community health worker, she's on her bicycle, she's in the rural village, and she gets about 3 weeks of power and use off this tablet without having to recharge. So we've got people who have both hardware and software knowledge to be able to use a lot of things that we think are no longer the absolute latest in technology. Antenatal care, PMTCT, all those sort of things that you hear about, diagnostic data information, I like all that, I care about all that. What I care about more is that you take an approach that's much more systematic. That, when you come up with your fancy solutions and we're using a solution, that if you're capturing something for a diagnostic tool, that we can reuse that information over and over. One of the examples is, let me go back a little bit, is we're working with a number of partners, and they're going out and they're capturing the GPS locations of health facilities. And then the next partner comes in and captures the GPS locations of health facilities because they care about orphans and vulnerable children. And then another partner comes in and they want to capture all the health facilities because they care about early infant diagnosis. And then another partner comes in and they want to capture GPS locations because they care about PMTCT. So what we've tried to do is say, listen, if someone already has a GPS lat longs coordinates, we'll just share those with you so that way that data element can be used. You don't have to do that work. That's a cost savings for you. So trying to get the different mHealth projects within a single country to share and use data is the challenge. It's just ourselves working together. So we've been trying to do very much in terms of publishing our information, publishing our data, making sure it's all out there, all open source, all freely available. So that way, if you want to go to rural Tanzania, Kenya, we've got data sets and information that you can already use. So that way, your projects can start off, instead of from zero, you can at least start off with data and information that's already been curated. So that's another pitch that I'm going to try to put out there. At the conference, Unite for Sight conference 3 years ago, there was another person on the panel, Dr. Rich Fletcher. He was doing mobile sensors. Rich, as a result of the conference, and I started working together and collaborating, and he's doing mobile sensors for babies and neonates. And so we were starting to introduce this into our projects and programs. He also has being able to take your mobile phone and be able to now record the temperature of the baby and the infants to be able to determine their vital signs and temperature using the mobile phone. And so he's doing a couple of pilots of this in India with Ames Hospital and a few other places. Again, as a result of collaborating here during Unite for Sight. One of the issues we have is identifying people. In the US, we have social security numbers. That's very easy to identify people. In a lot of the countries, there's no unique identifier. So how to come up with a unique identifier for adults and infants and children and babies. So they're working on, Rich has been working on a way to use your mobile phone as a palm biometric device to record the palm print as a unique identifier for adults and patients and pediatric patients. So we're going to be doing a couple of pilot tests in Haiti around this. And it's low end, costs maybe no more than $10. So again, we're trying to use technology that is low end but sustainable, that people can afford. This is a Swassi slate. It's used in India. And Dr. Kanoff, I met with him as well. But that is a tablet, of course, an Android tablet, but he's got mobile sensors that records vital signs, it records blood pressure, water, heart rate, but you give it to community health workers, so when they're going out in the field, they can record the diagnostics and send the information back to the community. And again, this is less than $10 worth of materials. All of this is data collection, all this just needs to be in a sort of a systemized way. So there's another piece of open source software that I'm advocating for people to use called DHS2 that allows, if you're collecting with different mobile devices and different systems that we all can then start sharing information together versus just developing stovepipes and vertical reporting that was the old days. So we're trying very hard across maternal child health programs, TB programs, to have a way for us to share information. So if you're familiar with the health facility, you get a lot of different partners who are working on the health side, the HR side, the financial side. So we're trying to sort of bring them all together around some common data elements and common sharing of information. That way it's sustainable in country versus having a new technology that doesn't plug and play to the ecosystem. The old days, meaning 2 years ago, these were sort of the state-of-the-art technologies that people are working on. So you went to a Ministry of Health, they knew Microsoft Access, they knew Excel, your technologies and what was developed around these types of tools. Today, now, I'm seeing more and more of the MPH students coming in, and the technologies that they're using are, Tableau, social tools, social media tools, e-learning, what's called NoSQL databases, cloud, of course. A lot of the ministries of health, a lot of the people in the rural, they don't have access, they don't understand, we're sort of leaving them behind. So I'm trying to have efforts where as appropriate, where we start doing training, capacity building on these technologies for those in the countries. So that way we're not leaving them behind as well. We've got a project that we're kicking off in rural Pakistan and Bangladesh around using social media. So if you're, again, a woman and you go into a clinic and they don't have contraceptives available, you can do an SMS text and say, okay, at this facility, it wasn't there. However, some countries, the women don't feel comfortable with SMSing a text message. So you have to have different modalities. So we also have an interactive voice response system. They can dial a number. They can tweet, Facebook, all different ways. So the important part is not to have just one single solution or one single technology to be able to capture information. And I think that's very important in order to be culturally sensitive, because not everyone wants to use their mobile phone to get HIV information or pregnancy information. So this is, again, an important lesson that we learned for some of our programs in Bangladesh and in Pakistan. Sorry. Again, I mentioned about stockouts, being able to track stockouts. We're doing a lot of e-money, mobile money, being able to transfer funds. We're doing mobile money not because it's fancy. I'm doing mobile money because I'm trying to reduce the corruption. If you're paying someone one kobo note, $1, by the time it gets to them, it's only 50 cents. So by using mobile money, I'm bypassing all those other people who are taking a percentage and giving it directly to the beneficiary. And that's been very, very helpful in our programs. Again, mentioned about the mobile patient identifier using smart cards. And we're also using gaming. So we're trying to take the model from we're developing some software for gamers, for the youth, how to get them participating in that public health ideas and work. So we're developing with Matchboxology, who has a Gates Foundation's grant, some social mobile games for them as well, for youth. And you'll be able to go on and be able to use Mixit and others for them to access these games. The reason why I like the gaming technology is because if you understand about games and you go to a rural clinic and you ask to see what's on their phone, what applications do they actually have on their phone? They probably do not have your fancy software that you developed. They usually have, a game. They usually have maybe a calendar or a calculator or these type of things. So we've taken an approach of taking all of our software and we made it available, made it available on Google Play and on Microsoft. And so they're just able to download our software as part of a game type distribution model. So right now we have about 10,000 healthcare workers who've just downloaded the software for community health workers and they're using it. And so putting things on Google Play and Health, and it makes it a lot easier to both track who's using it, and secondly, to get the distribution model out there. And so the gaming technology helped us to think about that approach. For public-private partnerships, again, I mentioned the curve goes down if you depend on donor funding. So I've been working with IBM in Kenya, and we've got a collaboration with Intel Corporation. For people who want to learn about mobile health training, Tech for Change is fantastic. But if you want to learn about some of the standards and interoperability and how to use mobile health, mHealth Alliance is a fantastic resource, absolutely fantastic resource about experiences, about other people who've done mobile health projects, the success and failures, and it's all there as well. So we're part of the mHealth Alliance, but it's the experience that's more important that's there. So I'm happy to partner with other people as well. Around technology, especially social entrepreneurs. So 2 years ago, Melissa Menke was up on the panel, and she has a micro clinics around called Access Afia, where she's offering a franchise model. She's offering health services to the slums in Kiribati I mentioned earlier. And so what we've done is, and it's hard to see, but we have our software, our open source free software running in her clinics. So I'm actually very pleased to be able to partner with people to provide them resources that you have. So you have a wonderful idea, let's embrace those sort of things, but let's embrace it in a way that makes it sustainable. So that way it's not just a one-off and it's fantastic and you make your money and you're a rich billionaire and we're still, plugging away. We would like to have an approach that makes it sustainable so that way, the countries can use it long after we've passed on. So that's my presentation. I think there's a question and answer session later, and I'll be happy to take questions then. So I apologize if I use too much technology terms or that sort of thing. So, forgive me for that, but I'm open for questions later as well. So thank you.